Okay, I've just seen I've actually got 15 minutes, not 20 according to the counter, so I'll have to talk a little bit quicker. Okay, I've got a little brief talk about ECMO and really what's important this year. ECMO, as we're aware, was first reported in 1971, and since then there's been a number of randomized trials in neonates of ECMO versus conventional therapy, and very little really in adults. And really it's remained until a few years ago was really very much an enthusiast-driven therapy until 2009 when along came H1N1. We'll all remember what happened that year with a fairly rapid movement around the world of this new pandemic influenza. Quite rapidly came down to Australia and New Zealand. And we saw a very large increase in the number of severely ill, unusually quite young patients. It was a rapid onset illness with a short prodromal period, and patients who were severely ill had a short hospital stays prior to coming to ICU, and then many of them required mechanical ventilation, and a proportion went on to require ECMO. We'll be familiar with the severity of the lung injury that these patients had. So during 2008, the year prior to this, you'll see that there's really just a low level of ECMO use in Australia and New Zealand. There was probably, at that time, only about 5 or 6 active ECMO centres, but it progressed quite rapidly in 2009, and from a baseline rate the previous winter of only 4 patients, requiring ECMO for ARDS. Over the period of 2009, there was 68 patients, so quite a dramatic increase, and in fact, an increase of 0.15 per million population, up to 2.6 per million population, so very, very significant. The burden, as you'll all be aware from that time, it was a significant public health problem because we moved from a baseline daily ECMO workload of perhaps only 1 or 2 patients on ECMO at a time for a population for the 2 countries of about 28 million people, up peaking to over 20 people on ECMO during the peak of that. Of interest, obviously, a couple of things were done differently then. First of all, because it was actually quite a lot of these centres, there were 15 centres in Australia and New Zealand that actually put patients on ECMO during that pandemic. But many of them had little or no experience of using ECMO prior to that year. So of interest, there was a high percentage of the cannulations done by cardiac surgeons or vascular surgeons, which we certainly don't see now. And also, there was a significant number of the patients that were transferred on ECMO, which in itself was quite an unusual achievement. Back then, there was actually only probably 2 established ECMO transfer services prior to this in Australia and New Zealand, so it was quite a large number. There was also significant complications with 60% of patients having significant infections, and I'll talk about infections and ECMO a little bit tomorrow. The outcome, though, from these patients was very good, with more than 70% of them surviving to ICU or hospital discharge. And this we published in 2009, which was coupled with another publication at the same time from the UK, which was the first randomized controlled trial of ECMO for severe adult respiratory failure, which was called the CESAR trial, which was done in Leicester in the UK. This is the first trial that showed a benefit for ECMO, published the same month as our article, but the interesting thing from it was a very unusual design, and probably without the if you like, the push that came along from H1N1 probably wouldn't have changed our practice significantly. So what has happened since from 2009 towards 2014, which is what I'm supposed to talk about? And there's been a very significant growth in the number of units and also in the number of referrals, probably also due to increased awareness of the availability. What we can see, and this data comes from ELSO, which is the the Extracorporeal Life Support Organization registry, which at the moment is the biggest and the best registry of ECMO use. And we found that the baseline has been steady for a number of years with 120 to 130 units contributing data to ELSO. But we saw a very significant increase since 2009, with 20 to 30 institutions being added each year, as well as a huge increase in the number of cases. So numbers of patients having ECMO and their data submitted to the registry. And it's important to remember that not all ECMO centres put data into this registry, but it's basically doubled over about an 8-year period. In Latin America, there is now a little bit of data. This is fresh out of ELSO. Up to December last year, you'll see there's a slow but steady increase in the amount of ECMO being done in this portion of the world as well. And worldwide, when you look at the increases, the main reason we're seeing these huge increases in numbers isn't in neonates, which is established treatment and proven treatment. It's not in pediatrics. The biggest increases we're seeing is in adults, so ECMO is very much now established, I think, as an adult therapy. And we've seen since the swine flu pandemic an increase of a 5-fold in the number of adult respiratory cases submitted to ELSO, and also a 4 times increase in the number of cardiac cases, which is quite interesting because it probably just demonstrates that there's more equipment, more expertise, and more units out there. And in the nice summer months when there's less respiratory problems going on, they tend to put people with cardiac problems on to make sure that their expensive equipments get used. I'm only being a little bit cynical. Okay, there's likely to be a very significant underestimation of this because new centres probably take a few years before they become ELSO registry members and ELSO registry contributors. So the actual number of patients getting ECMO is far more significant. I think we can say that ECMO is here to stay, despite the fact that there's actually very little best quality evidence for efficacy and cost effectiveness. And this actually may be hard to achieve because of lack of equipoise at certain centres. So the big question for 2014 is, which patients should we treat with ECMO? It's as we said, it's a really expensive, it's a very resource-intensive treatment. And the current guidelines on who you should use it on are generally based on local practice and the outcome data from ELSO, which is quite positive. Despite all the new units doing ECMO, we're seeing an increase in survival from ECMO used for respiratory indications. It now sits around 60%. Versus around 40% for cardiac indications. Obviously, this is raw survival data, so it doesn't take into account changes in case mix. The other thing that we're seeing is perhaps we should be able to use some scoring systems, but until very recently, the only ones around were an ECMO-Net score, which was only for H1N1, and Preserve score, which has yet to be externally validated, and they're both from Europe. Until about a month ago when Matt Schmidt, who's a French intensivist who's currently working as a researcher at the ANZIC Research Centre in Melbourne, and others, produced the RESP score, which is a survival prediction score for ECMO, and I'll spend the next 6 minutes talking about that. It's really interesting because it's derived from over 2,300 patients from 2000 to 2012. Importantly, though, more than 2/3 of these patients are in the last 4 or 5 years of that. So they're, if you like, in the era of modern ECMO. There were significant changes to technology between sort of 2000 and 2005 that made ECMO a much more sort of viable option. They used multivariate analysis to identify variables that were independently associated with survival. And that survival is actually survival to either hospital discharge or transfer, because that's the data collected in the ECMO registry. Initial analysis suggested that the RESP score should be made up of these things, because all of these decrease the chance of survival. But they also found that primary diagnosis of bacterial or viral pneumonias, aspiration or trauma or burns increase the chance of survival. as well as the use of neuromuscular blocking agents. It's important to note that all the things they looked at were what you could see before you put a patient on ECMO. The RESP score was designed using 12 commonly available pre-ECMO variables. And what you actually do is you work through the worksheet and you assign a score to each of those variables. And it gives you a total score between -22 to +15. So it's an unusual score because it doesn't start at 0. But it shows that lower scores have a lower survival, and they've actually demonstrated very clearly that there's a very strong relationship between this new semi-validated scoring system and survival. The highlights of the other work they did was they've shown that patients with severe asthma, although the numbers were very low, the survivability of severe asthma requiring ECMO is really high. And they also noted that patients with viral pneumonia had a much stronger chance of survival with an odds ratio of 2.2. And this actually remained valid when you actually corrected for other variables, given that most of the viral pneumonias are obviously since 2009. Of note also, and perhaps slightly counterintuitive, is that the initial oxygen status was not a predictor of survival. So the amount of oxygen a patient requires before they go onto ECMO has no bearing on their chances of survival. They also confirmed what we thought we all know, that was if you're on a ventilator for a lot longer before you go on ECMO, you do badly, but demonstrated quite convincingly that if you're on a ventilator for less than 2 days and go onto ECMO, it's associated with a better outcome. So once they'd completed this form, they externally validated against the 140 patients from the French PRESERVE study and showed a area under the curve of a receiver-operator curve of 0.92, which shows that it's an extremely accurate and useful scoring system. It does await further prospective validation, but it's likely to be a very useful tool for assessing which patients will benefit from ECMO and also identifying patients for future clinical trials. So there's the scoring system for you, but to make life easy, the authors have made it available online, so if you ever have a patient in front of you that you're considering for ECMO and want an idea of their chance of surviving, you can jump onto that website. It is only in English, but you put in the data that's there, which should be available on all patients before, and it will give you a little bit of information that might influence your decision on whether it's appropriate or not to institute ECMO or transfer a patient to an ECMO centre. Thank you very much.